Lots. High threshold.
High threshold. Okay, so do a quick introduction of yourself and then talk about your project. That would be great.
Okay, great. So my name is Evan Graboyes. Guess I can just share my slides. I am a head and neck cancer surgeon at the Medical University of South Carolina and a member of the Cancer Control Program of the Hollings Cancer Center and a former MRDA awardee. And as part of my MRDA award, I submitted a KO8 to NCI, and now I am resubmitting my KO8 in about a week. So this is going through the research part of the KO8 at least. So happy to share the research and then both take feedback and or if people are actually interested in participating when it becomes a future multi-site study. So very briefly, for those of you who are don't take care of people with head and neck cancer, head and neck cancer affects the mouth, throat, voice box, neck. It results in about 14,000 deaths annually in the United States. Unlike many cancers which have screening tests, head and neck cancer does not. And so most patients present with local regionally advanced disease and as a result have relatively poor survival despite intense treatments which include combinations of surgery, radiation, and chemotherapy. So we're searching for strategies to improve survival for this disease with suboptimal outcomes. One of the major contributing factors for poor survival are delays in cancer care, and the delays between when people have their surgery and when they start their postoperative radiation therapy or port are a key driver of this high mortality. So people who have a delay, which our guidelines define as more than 6 weeks after surgery, have an 11% absolute decrease in 5-year survival. And just for perspective, like the single worst pathologic feature you can have in your tumor results in about the same size mortality increase. So it's a very, these treatment delays are very impactful. Treatment delays are also really common. So over half of head and neck cancer patients who have surgery and radiation afterwards don't get guideline adherent care. And that's because there's a relatively complicated care delivery pathway that's potentially modifiable.
Evan,
in addition to being...
Evan, we're not seeing your slides.
Oh, well, let me try slide share again then.
There you go.
Oh, perfect. Were you seeing me or Rob?
We were seeing you and Rob.
Oh, well, that's terrible. Okay, perfect. So this was the first slide. This was the second slide. Good thing I wasn't doing anything embarrassing. Okay, so head and neck cancer also has a disease with significant racial disparities in outcomes. African Americans have about a 20% absolute decrease in 5-year overall survival and about 50% relative decrease. And delays starting adjuvant therapy are also a key driver of racial disparities in survival, as African Americans are significantly more likely to not start their adjuvant therapy in a timely fashion. So we know that getting head and neck cancer patients timely postoperative radiation therapy is a key strategy to decrease mortality and racial disparities in outcomes. Unfortunately, no effective interventions exist, and in large part it's because we don't know the barriers to timely adjuvant therapy. So patient navigation is one potentially reasonable strategy, although most current patient navigation modules exist for initial cancer treatment, so getting people in for screening or treatment initiation, not getting people already in the cancer care system through multimodal sequential cancer care. And it's likely that the type of care coordination and barriers that are faced by people who are already in the cancer care system are significantly different than people coming in for pap smears or colonoscopies. So this is the study schematic we're proposing for our KO8 research. I probably should have put these slides in a different order, but I couldn't fit all 3 aims in one page. So it's a 3-phase study, each corresponding to an aim. Aim 1 is to identify the barriers to timely equitable adjuvant therapy. And we're going to accomplish this aim through a combination of key informant interviews with patients and providers. We'll use this information about multi-level barriers to head and neck cancer care to inform development of a multi-level theory-based intervention, which we call ENDURE, which is navigation for disparities in untimely radiation therapy. And then we're going to pilot test ENDURE with 15 head and neck cancer patients in a single-arm feasibility and acceptability study, which will be supplemented with a qualitative evaluation of the intervention with patients and providers. And then we'll use that data to refine ENDURE, which will then be tested for preliminary clinical impact on delays and racial disparities starting adjuvant therapy in a randomized pilot-controlled single-site study of 75 patients per arm. This is the conceptual model we're working with. So the idea is that barriers to timely, equitable adjuvant therapy are multi-level in nature. And this multi-level nature is reflected in the structure of Endure, which targets patient, provider, and system level factors. And through a barrier reduction plan targeted at these parts of the care delivery pathway, we hope to improve clinical outcomes, which is the rate of delayed port and delayed racial disparity starting adjuvant therapy. So a little bit more about the specifics. So specific aim 1 is to identify the multi-level barriers that contribute to delays starting postoperative radiation therapy among head and neck cancer patients. And so this will include head and neck cancer patients and providers who undergo key informant interviews to identify the multi-level barriers causing delays starting adjuvant therapy, which will both refine our model and then inform the Endure intervention. And based on some pilot data that we've already gathered from patients and providers, it appears that key themes of barriers contributing to delayed port will include care coordination, treatment toxicity, interpersonal support, knowledge, and social determinants of health. And just a little bit more about these. So the patients and providers will both be purposively enrolled. So based on known risk factors for delayed adjuvant therapy, we'll stratify patients based on race, location of adjuvant therapy, so whether it's at the same or a different place from where they have surgery, and insurance. And then we'll also stratify providers based on their type of practice. So whether it's their practice specialty, so surgery, radiation, medical oncology, the type of practitioner, nurses, nurse practitioners, and nurse practitioners and physicians, and then their practice setting. So whether they're at MUSC or somewhere else in South Carolina, so that we can get a really comprehensive and robust understanding of the multi-level barriers. So from that aim, we'll then use an intervention mapping approach to design the patient navigation intervention, which is Endure, which will then be pilot tested to accept feasibility and acceptability. So feasibility, pardon the typo, will be measured by enrollment, dropout, and the navigator caseload, and acceptability will be measured using 2 validated measures of satisfaction with navigation. And then patients and providers will both undergo semi-structured interviews at the end to understand more information about barriers and facilitators to implementation, as well as refined content delivery, timing of the intervention. And so we hypothesize for this aim that our clinic-based intervention will be feasible and acceptable. So this is just a tiny bit about what Endure looks like, and I'm happy to certainly more talk about the details of the intervention, but it's a clinic-based patient navigation intervention that targets delays in racial disparity starting postoperative radiation therapy after head and neck cancer surgery. It consists of 3 in-person sessions of manualized patient navigation, which targets these theoretical constructs. And there are additional, these are the in-person sessions which are scheduled at their original surgical consultation before they leave the hospital and at their first post-op visit, which are 3 time points in which approximately 100% of people will have face-to-face contact here at MUSC. So it's likely a feasible delivery session, but then there's also flexibility for additional modalities of contact by text message, email, phone, as needed for the barrier reduction plan. So the idea will be that each patient will meet with the navigator in the beginning. The navigator will do an intake assessment, develop a barrier reduction plan, and this will be iteratively and longitudinally both acted upon and updated as new barriers arise. So treatment toxicity before surgery may be not a big barrier, but after surgery may become a larger barrier. And so these barriers will be constantly evolving longitudinally as the barrier reduction plan gets adjusted. And then we've developed EMR templates for logging and coordinating some of these things. And then patients will receive some deliverables to help them get through the intervention as part of Endure. So there's patient and provider information that then get distributed to help coordinate care. So this is the schema for the single-arm pilot study for how we're going to assess feasibility and acceptability during this aim. So it's 15 patients will be in the single-arm study. The intervention takes about 3 months. Feasibility gets measured by enrollment characteristics, dropout, missed encounters, navigator caseload, and navigator time allocation. Acceptability gets measured with these validated satisfaction tools, and then patients and providers undergo qualitative analysis of the intervention, which will then take us to phase 3 of the study, which is the pilot randomized controlled trial. So after phase 2, we'll gather the information that we need about feasibility and acceptability and refine the intervention as needed. And then it'll get piloted in phase 3. which is the pilot randomized controlled trial of Endure compared to usual care. And usual care in this situation will just consist of sort of standard clinical encounters with the multidisciplinary head and neck cancer team. We will gather the primary outcome measure is rate of delayed adjuvant therapy. And then we're also going to measure key care delivery processes, which we know were related to timely adjuvant therapy, as well as the theoretical constructs underlying Endure. And we hypothesize that our intervention will improve the timeliness of adjuvant therapy for head and neck cancer patients and decrease the difference in delays between white and African Americans relative to usual care. And so this is the trial schema for the pilot randomized controlled trial. So baseline will measure some characteristics about our cohort and the theoretical constructs that we think Endure is targeting. Patients will then be randomized to Endure versus usual care. We'll measure their treatment toxicity while on the intervention, fidelity of the navigator to delivering Endure, some of the barriers that they're addressing, system level care processes we know are necessary to deliver timely care, and then look at our clinical outcome measures about delays and disparities starting adjuvant therapy, and then effects of the navigation on the theoretical constructs that we're targeting. And then again, patients and providers will undergo semi-structured interviews to better understand the implementation and effect of the intervention. I'm a fast talker, hopefully I did okay. So in conclusion, delays starting postoperative radiation therapy are an appealing therapeutic target to improve survival and to decrease racial disparities in head and neck cancer outcomes. We are already working on identifying these multi-level barriers, which can be done robustly and comprehensively through key informant interviews. And we're currently in the process of developing, implementing, and then testing our Endure, our patient navigation intervention. So thanks to you guys for helping get the research going, and happy to take questions sort of more specifically about any part of the ongoing project. Oh, and these were the MRDA award and then my K-12 award, and then the rest of my mentorship team. So thanks, everyone.
Thank you very much, Evan.